afternoon everyone. I'll be speaking about the upper lid blepharoplasty. Okay. So dermatochalasis is a common age-related involutional change which is associated with a upper lid where there's excessive redundant skin folds and there's fat prolapse through the orbital septum. So steatoblepharon basically is the prominence of the eyelid fat pads and applies to the upper and the lower eyelids both. It may be associated with the weakening of the orbital septum and the overlying orbicularis muscle and skin. So this is how dermatochalasis presents with redundant skin without any fat prolapse in the upper two pictures, and this is noticed more in the down gaze, while some presents with both upper and lower eyelid fat prolapse along with the redundant skin. Excessive medial bulge results in the medial fat pad which does not directly lie over the aponeurosis and it's partially covered by the orbital septum, hence it cannot be retracted back completely by the contraction of the septum. Now, there's also preseptal orbicularis fat which can be contributed to the upper lid fullness, as you can see in the picture. Any lateral upper eyelid bulge should also be noted as it may be a prolapsed lacrimal gland, as you can see here. Understanding these anatomical details allows one to examine the various bulges on the upper eyelid accurately. So now the topography and the senile changes of the eyelid. In the young age, the brow position rests at or above the superior orbital rim. The lid brow junction shows a convexity, and ideally the ratio of the tarsal platform to the distance between the upper lid crease and the brow should be 1.16, which is the golden ratio. And the upper lid covers the upper limbus approximately 2 mm below in the primary gaze. In the old age, what we see is the upper periorbita, it demonstrates brow ptosis. The brow position is below the superior orbital rim with sunken superior sulcus, and multiple folds and blepharoptosis may also be accompanied. The lower eyelid shows bulging periorbital fat and prominent tear trough deformity. So the assessment of the senile changes and the periorbital structures will allow the surgeon to determine the need to reposition the brow tail, or if a direct lid surgery alone can address such temporal hooding. Now, as you can see here, there's temporal hooding, which is a common finding in elderly population. It is a combination of the temporal brow ptosis and the lateral dermatochalasis. The degree of the dermatochalasis can be more pronounced in certain diseases like thyroid following trauma, Ehlers-Danlos, blepharochalasis, xanthelasma, and angoneurotic edema. Now, the question arises is, do all the cases of these need to be treated? What are the indications of the surgical management? And what are the different options that are available? Now, for temporal hooding, there is excess laxity with temporal hooding which can interfere with the superior and the superior temporal vision, which may make the patient constantly raise the brows or the chin in order to see. Now, these patients, they usually complain of difficulty in driving and also some difficulty in seeing the traffic lights. Now, the visual field that was recorded from the right eye of this picture of this patient is showing a superior scotoma, superior arcuate scotoma, which is most likely because of the superior lid drooping. Now, the other ones will be your dermatochalasis with different types of upper eyelid bulges. As you can see, this male patient has ptosis. So, here is a video showing to upper lid blepharoplasty along with a mulomuscle resection correction that was done for this patient. As you can see, we're making the marking and then we'll be injecting local anesthesia.
The Muller's muscle actually lies just beneath the conjunctiva.
Yeah,
so the marking has to be done before you give the anesthesia, and then after that you inject the anesthesia and apply the clamp.
Yeah. So as you can see, we've applied the clamp and now we're taking the sutures below it. I'm sorry, I'm unable to fast forward it. So I'll just describe it as it's going along. As you can see, we're taking the sutures just below the clamp. It's extremely important we take it just below the clamp so as to avoid excessive resection. And then we'll be taking an entire full thickness suture, incision, and cutting the whole of the mular muscle complex with the conjunctiva. So, the dermatochalasis with different upper eyelid bulges also includes a lacrimal gland prolapse, which we can see in this very young patient, which causes lateral hooding and also brow ptosis. Now, in this video, we see an incision is made and we'll be going ahead with the lacrimal gland repositioning. Okay. So, as you can see in this picture, there is a pre-operative picture with the lateral hooding and the lacrimal gland prolapse, and the post-operative picture is very evident of the lacrimal gland repositioning that we've gone ahead with. So, another indication will be your downgaze ptosis, which is a droop of the upper eyelid that occurs because of the redundant upper eyelid skin and interferes with reading. In this elderly gentleman, as you can see here, another indication for a blepharoplasty will be your lash ptosis. Now, the lash ptosis, they commonly cause ocular irritation and entropion because of the dermatochalasis. So, the constant skin-to-skin irritation, it may also cause dermatitis. It is a very common finding in the Northeast Asian population, which shows that there is a corneal irritation and staining. So, because of the constant irritation of the conjunctiva and the cornea, there is reduced tear clearance, ocular irritation with increased cytokines and increased inflammation. So, this we've covered in a paper that is written by Dr. Kasturi ma'am with long-term changes in contrast sensitivity and corneal topography and higher order abrasions after an upper lid blepharoplasty. So, this shows that there are changes in contrast sensitivity after an upper eyelid blepharoplasty. As you can see here, this patient presents with a lash ptosis, and post-operatively the lash ptosis is corrected, the upper eyelid contour is directed well. Similarly, another patient here with lash ptosis and post-operative view of the up-directed eyelashes. So, another change after a upper lid blepharoplasty will be your change in corneal topography. So, there have been significant reports of improvement in contrast sensitivity of the patients who undergo blepharoplasty surgery for dermatochalasis. So, here are these pictures, and the redundant and the skin, overhanging skin, it blocks the light that is entering the eye, which causes more diffraction. So, after the surgery, this diffraction is reduced, and this helps in the patient seeing well, and there have been patient satisfaction reports of post-surgical improvement in their contrast sensitivity. So, as you can see, the higher order abrasions, there is reduction, and the lash ptosis correction causes increased contrast sensitivity, improving the functional visual acuity. So, reduction in that increases the point spread function and more vivid retinal images, and this leads to a better visual acuity. So, the technique will be your there are 3 types of skin marking incisions that that madam has shown previously: the classic Rees incision, scalpel shaped incision, and the Bell-in-Vias incision. So, we follow the one where there is the most important aspects marking in the upper lid will be your skin excision and the skin crease marking. So, one should take enough amount of time to mark the symmetry, as is going to be the concern for the most of the patients. So, as you can see in the pictures, the point A is marked 10 mm above the central lid margin. B is marked at a 6 mm from the medial, above the medial canthus. C is marked at the lowest point of the lateral hooding, and the patient is asked to look up, and the point where the eyelid margin is in opposition to the thick upper eyelid skin, which is approximately 2.5 mm above this, a point D is marked. Now, this signifies the vertical height of the skin marking. So, another point E is marked 8 mm above and at an angle of 15 degrees from point C. So, symmetry is the key, because blepharoplasty is an extremely important surgery. It will affect the patient's confidence later on. So, always stretch the skin with some degree of redundancy, but care must be taken to remove the conservative amounts of orbicularis muscle. Incision, dissection, pre-tarsal orbicularis should always be preserved, as this will affect the blinking if it is affected. And patient's age, the degree of redundancy, whether any brow lifting is being performed or not. So, small incisions over the septum, will allow you direct access to the pre-aponeurotic fat pad. For the upper lid blepharoplasty, we can always ask the patient to close their eyes and push from the lower eyelid. That way the fat can be pronounced and can prolapse once the incision is given in the septum. So the central fat pad, as you can see, is visible. There is a medial fat pad. Okay, should I continue? Okay. So because my time is up, I will just quickly go ahead. So yeah, so basically addressing the temporal hooding, skin crease formation, filling the A-frame central eyelid deformity and internal brow lifts are important. So temporal hooding you can go ahead with, as ma'am has mentioned, extended blepharoplasty, where only for the functional ones you have to go beyond the lateral canthus and not for the cosmetic ones. And the skin crease formation, a well-defined skin crease needs to be designed, one with use buried vital sutures from the subcutaneous tissue to the aponeurosis, or from the aponeurosis to the skin closure. So I'll just skip over this. Internal brow lifts, KB ma'am has mentioned quite a lot of it. Yeah. So the art of blepharoplasty is to know how much to reduce, how much to preserve, and how much to reposition. So, thank you. I'm sorry it extended beyond the time.
Thank you, Dr. Sonali. So after your talk, everybody can start marking and doing step-by-step skin and orbicularis upper lid blepharoplasty. For the greater indications, maybe a couple of more ICs will be required. But this is something because we are addressing, I'm sure, ptosis surgery when you're doing it, start doing the blepharoplasties in those, especially the adult patients, and you'll start getting a hang of it.